Finally, we have the obstructive diseases of the gastrointestinal tract. So, to obstruct means to make movement difficult. So, these disorders are going to involve something that is going to make the movement through the GI tract more difficult. So, something that obstructs movement. Okay, so there's a couple of different types of obstructions that we'll talk about. First off, I want you to remember that all organs are very high in tissue factor. So when they do become damaged, they release tissue factor, which starts the clotting cascade and ends in the formation of fibrin. So when there is a high amount of fibrin, that is going to lead to scar tissue formation. And scar tissue formation can result in a variety of different obstructions, one of which is adhesions, which is going to involve the connecting of organs to other organs. So this is adhesions. Then we'll also see strictures, which is healing within an organ. There are herniations, which is when there is a connection site maintained, but a part of that tissue has herniated out of its place where it should be. So we'll talk about different hernias. One that's common in the abdominal region is called the umbilical hernia, so through the umbilicus or belly button. And then there are tumor obstructions. So colon cancer, we talked about a lot in the cancer chapter. It's the number 3 most common chapter in adults in the United States. And you will see changes in bowel function associated with colon cancer because of the obstructions it can cause. So when we think about these different disorders and pathology, consider, diarrhea and constipation and what your most common result would be, but also keep in mind that it's important to rule out the prevalence of colon cancer. One fun fact is that you won't see small intestine cancer. You will see it in the colon instead, the large intestine. And that's believed to be because we have a microbiome in the large intestine. We have a native bacteria colony that live there, whereas we don't have that in the small intestine. So some have postulated that that microbiome has alterations that can lead to cancer in predisposed individuals. So it's an interesting field of immunology right now, but just keep that in mind when we talk about GI cancers and colon cancers. It's going to involve the colon, the large intestine. So the first obstruction is a herniated one, so a herniation out of the place where it's supposed to be. So it maintains the site of the attachment, which makes it different than a prolapse, but it's a movement out of place. So this can happen any place there's a weakness in the abdominal wall. So a natural one is the inguinal cavity, which is more prominent in males. There's physically 2 sheets of tissue that overlay upon themselves. And we'll take a look at that picture in just a minute. But that lays between the scrotum and the abdominal cavity. And then everybody has an umbilicus, a belly button. So that could be a place where intestines loop out. That's really common after pregnancy because the abdomen is so stretched that it stretches out the umbilicus and some intestines can pop on through. This can also happen in weakened scars. So if somebody's had an appendectomy, if they've had any kind of removal of endometriosis, an ovarian cyst, even a C-section, those allow places for scar tissue to form that can involve a weakness in the wall. So essentially, you just have the looping out of a loop of intestines, which is going to limit the ability of feces or other bowel contents to move through the intestines. If there is significant pressure, it can actually collapse the veins in this region and then lead to strangulation. So just like you would strangle someone around the throat, this bowel can be strangled and we can lose blood flow to this area that would be receiving it. So that would be an ischemic injury, so lack of blood flow and lack of oxygen, leading to tissue death, necrosis, and then possible gangrene. So this is something pretty easy to treat. They implant a mesh. So in this case, they would just tuck the intestines back in and they implant a mesh right here. It's an outpatient surgery. It's done laparoscopically. It's very quick. And chances are that it won't come out again because now we've reinforced that area. So a lot of people will ignore these and say it's no big deal, but as you can see, the end result, if they're not treated appropriately, could be really catastrophic. And the treatment is very, very quick, just a simple mesh implantation. So here you see two other examples of a hernia. This is the same thing. This is an umbilical hernia in an infant. So this is just a loop of small intestine that's came out of the umbilicus. So again, this would be put back in, a little piece of mesh put there so it doesn't happen again. Okay, this is the inguinal canal. So you have these deep muscles of the abdomen here, kind of creating this V shape. And then you have the hip flexor muscles, which go this way. So between those, so you have these deep muscles, they are folding and they lay right on top of these hip flexor muscles. So that means there's an actual open spot right here because they just lay one on top of one another for the intestines to loop through. So this is a herniation through the inguinal canal, so just this open space here that allowed the, whoa, sorry, that went rogue. Come back, hernia. So that allowed the intestines to then migrate into the testes or the scrotal areas. So that same thing would be treated by putting the intestines back where they belong and implanting in a mesh so that they can't leave throughout that weak spot anymore. Okay, then you have scar tissue. We have first adhesions. Adhesions occur when there is activation of the coagulation cascade and then the formation of fibrin. So this is fibrin, this is your scar tissue. And in this case, the fibrin has looped together and attached together a piece of the small intestine and then the omentum. We have a greater and smaller omentum, which is something that helps anchor stuff to the wall. But what you can see, if this was relaxed, this would lead to like a pinching in of the small intestine, which is going to limit passage through. So this could be because there was a past surgery or damage to a tissue. This would be removed by removing this scar tissue. You'd have to go in laparoscopically and cut that off. So it's easy to treat once it's found. So people need to pay attention to their bowel movements so we can figure out if there's any changes and what caused those changes. In a healing surgery, there's two types of healing. There's primary healing, where the edges of a wound are really close together. Like if this was a scalpel cut, like just two edges of skin have to heal together. And that happens really easily because they just migrate towards one another. You can put stitches in to help aid that process. So here's some simple stitches. So that's called primary healing. That's really quick and it's not a big deal. But when the edges of a wound are close or far away, so this could be from a surgery, or let's say that this was a perforation, and now there's a hole in these intestines and they're going to start to heal. Well, the way that secondary intention healing happens is in really large circular wounds like this, the edges have to migrate in towards one another, and the tissue actually like looks puckered. So if you think of burn skin, so skin that has been burned really extensively, how it's very tight afterwards, those are called contractures because the edges of this, they pucker together, they contract until the wound is closed. What that means is that it's going to take some tissue with it. So like in this case, this has healed, but now the scar tissue left over has puckered this tissue. So now we have a narrowing of the lumen. So this is due to, again, healing with scar tissue formation, but in a secondary healing, a stricture can form an obstruction because of this contracture that happens at the site of injury. In the worst case scenario, when there is a contracture, like here, let's say they have diverticulum that it could burst open or become damaged, tissue factors release, there's thickening of the wall, and now stool can't move. Well, that's called a bowel backup, and the stool will block all the way up, and then there will be a lack of transit of things from the stomach into the small intestines because your body doesn't want to take in any more stuff when there's all this stool blocked up in the colon. So people, they'll vomit from this because they can't put any more food in. So if you see people vomiting right after they eat, that could be a cause of an obstruction or from an obstruction. So again, think about your your tympanies. So if you percussed on this belly, it wouldn't sound like air, it would sound like it was really full. So those percussions are really useful. Also, if you're listening to a belly like this, would it have increased bowel sounds or decreased bowel sounds? And remember, bowel sounds are telling you that things are working and they're moving. So if you are thinking to yourself, probably no bowel sounds, decreased bowel sounds, that's absolutely correct, because this isn't moving now because there's a physical blockage. So the way that this is treated, yeah, remove the blockage and then lower, what do you call it? Like an enema. You're going to take everything out. Colonic, there we go, lower colonic. An upper colonic is going from up here to remove things in the colon. You don't want to vomit out your stool, so lower colonic to empty that all out. Okay, other things. Interception is also called telescoping of the bowel. You can see this happen in really young kids following really strong bouts of diarrhea. This can also happen in newborns just because everything is really poorly anchored to the wall. Now remember, you've got an ileocecal valve, right? Ileocecal valve. It prevents things that have gone into the large intestine from coming back. In the case that there's really severe injury or really severe diarrhea or things are just moving really quickly. So here's a normal bowel, okay? Here we have part of the bowel that has telescoped or moved into the part of the distal bowel. They call it telescoping because if you had one of those play telescopes as a little kid and you took it out to like look at a pirate ship, when you put it back, you take the, here, let me draw it out for you, in case you've never seen a telescope before. I don't want to take it for granted. So you'd be looking out this telescope like, ahoy, matey, there's a star over your bow. So you'd be there like looking at your telescope, like being all piratey and stuff. You know what a pirate's favorite letter is? R, but his heart be in the sea. Get it? Yeah, that's awesome. That's so funny. Anyway, so there you are with your pirate patch on. So you're looking through your telescope at this guy over here on his pirate ship. So he's got some doubloons, plenty of doubloons. So your telescope doesn't stay that big. When you're done with it, you put it back down into the little piece so that you can carry it in your little pirate pocket right there. So the big pieces go into the little pieces. So that's called telescoping. So same thing here. Little pieces go into the big pieces. So here's a small bowel coming into the large bowel. Isn't that nice? So this happened because of a colon tumor. You can kind of see this happening here. And this abnormal growth pattern led to a stricture and led to this entering the large intestine. This most commonly happens at the area around the ileocecal valve where the ileum enters the cecum because it's such a big size difference. So yeah, newborns, kids, especially younger kids after very intense bouts of diarrhea, this can happen. And this has to be released, so surgically it will be released. They also do anchoring surgeries with this and the other disorder we'll look at. So they kind of put some mesh here to help attach this to the wall or the omentum so that it's not so movable, not so motile. This one is very dangerous. If you've had or heard of a big dog dying, this they'll say that their stomach twisted. So I'll draw a dog right here. I'm gonna have to get better at drawing with this little thing. So here's a big dog that kind of looks like a reptile, but it's not, okay? Bear with me. Here, we'll make a little snout on him. That doesn't look like a snout. Now I'm just putting my energy into drawing this dog. Ah! Okay, so let me start over again. I'm unhappy with this dog. Let's draw a dog. What is that supposed to be, an ear? Now it looks like a dolphin. Now it looks like a unicorn. One more time. Let me just draw a dog like this. Okay, here's a dog. Legs, tail, ears. There, woof. There. Okay, so you might have heard of their stomachs twisting. They're on all fours. So that happens right after they eat, especially when they eat really quickly. Their stomach is like this. So if they go and do a lot of activity, their stomach, when it's really full, it can twist. And when that happens, there's really nothing you can do. You have to dig a hole if you're going to bury them at home, because it just limits all of the blood supply, and then there's an immediate infarct and they pass away. We have a little bit more time because we are on just 2 feet. So we don't have gravity working against us in anatomy. So because of the way our stomachs are, they can flip on themselves. And there's about 15 minutes, 15 to, maybe you can make it 30, that would be tough, but usually 15 to 30 to untwist this piece of bowel. And if that's not done, then this all dies due to ischemic damage. And once it necroses, there's a hole and the contents then leak out. Then you have peritonitis, acute abdomen. They're positive for acute abdomen. And then that person goes into septic shock, and then the bacteria gets access to their blood. So that's called septicemia. So this is really dangerous. I knew somebody who had this on a flight. This happened, just they had a weird altitude and they had a lot of stuff in their stomach and they moved a weird way and then their bowels twisted. They made an emergency landing so the guy didn't die in the air. So it's pretty serious and you have to relieve it, otherwise death is imminent. Okay, the last thing is kind of bizarre. It's called an imperforate anus. And what this picture is showing you, there's a speculum that is in the vaginal canal. This is a female, just to allow you to distinguish between the vaginal opening and what should be the rectal opening. So here, there's a flap of skin covering the rectal opening. So this is called an imperforate anus. The anus failed to form and perforate all the way through the skin. So there's 2 different ways that this can develop. Either it's a really easy surgery and everything's developed normally underneath here, and you just need to snip away this piece of skin. That's really easy, and this is a case in this picture of this easy thing. You just cut that off, now it's perforated. However, this could be something where the more distal structures didn't develop, and if that's true, once you get in there and you find no rectum, no sigmoid, that's very difficult to treat. There's much poorer outcomes. It doesn't mean that you cannot live with it, but there tends to be urogenital difficulties there, and it's associated with also abnormalities of the lower vertebra. So that could be treated with colostomy bags and things of that nature because there is not a functioning anus that has formed. But the easier one is just imperforate anus, where it's just easily treated by incising the tissue that's covering the anal opening. Okay, and then finally, a very common disorder, hemorrhoids. So hemorrhoids are the names of the veins in the rectum. They're called the hemorrhoidal plexus veins. So technically everybody has hemorrhoids. We tend to refer to them only when they're inflamed though. So there's 2 types of hemorrhoids you see here. These are internal. So these are very inflamed internal veins that are now extending out through the anal orifice. And then this is an external hemorrhoid. So there's some blood that's collected in hemorrhoidal vein, but it's outside of the rectum. These are caused by constipation, mainly by straining. Western toilets, those things that we sit on in the bathroom, like those things that you sit on, they have the perfect seat to cause constipation because the opening in them is just about, yay big, and this is the seat that you sit on. So all of the weight is put onto this area around the rectum. So the longer you're there, the more you're straining, the more of a likelihood there's going to be a bulging of these hemorrhoidal veins. This definitely happens during delivery and pregnancy because there's more pressure on those. So that's why we tell people, we'll make this into like a person dressed as a flower now. There we go. Hi. You're not supposed to just hang out and like read the paper or look at your phone on the toilet, because the longer you sit there, the more likely it is for these veins to bulge out. And that makes you sad. He's a sad flower now with not a happy one. That's not a mustache. That's an unhappy face. So we want people to just sit, go to the bathroom when they're ready, try not to strain, and not hang out on the toilet. Other things that can help prevent them, fiber-rich diets so that you're not straining too much. If there's no fiber, there's no bulk to the stool, and there has to be hard contraction of all muscles. Stool softeners help. You can imagine how painful it is. This is a vein that is completely inflamed. There's a thrombosed area on here, so there's a little bit of a intravascular clot. So this looks really painful. Now this is the lumen that the feces have to fit through. So that's going to hurt really bad. So giving a stool softener makes it easier to pass that. There's ointments, there's topical ointments like Preparation H. There's also suppositories. So if they have internal ones, they can be given, they're like this kind of torpedo-shaped drug. So it can be inserted in here and then release its contents over the next hour or so. And then for really severe ones like this, the surgery to remove a hemorrhoidal vein is very easy. It's an outpatient surgery. They give local anesthetic, they snip it off, they tie up the rest, and it's not that big of a deal. The internal ones, like you see here, these can erode really easily because they're close to the external environment. There's feces going past them. That means they're likely to bleed. They can prolapse. That's what you see here. They're physically moving out of the rectum. That's called a prolapsed hemorrhoid. And then, like you saw here, there's a blood clot. So that's called a thrombus. So they can thrombose. External, those are the anal canal veins, not the rectal veins. Those could also become thrombosed, like in this picture, that's just coagulated blood. And that's going to be cause discomfort as well. So again, these can be treated topically with ointments, treated with the diet, but they can also be snipped off should they be that uncomfortable. All of these things, how are they diagnosed? Well, the easiest way to diagnose any of these is first, if you can see it externally, then you can look at it. If you cannot visualize it externally, then you're going to need to use some internal mechanism. So here, this is an endoscope, a scope that goes inside. So an endoscopic examination can be used to look, like here's a nasal one, to look at the inside of the stomach, the esophagus. These endoscopic things can also be used in colonoscopy, so they can visualize what's down in there. Also radiologic, so you can give barium to light up these structures on an x-ray. So here, look at this stricture that's developed because of a tumor. That's a pretty intense stricture that's leading to obstruction. So you can help visualize the contours and identify the location so you can fully evaluate and give a good diagnosis for what the motility problem is. Okay, I am not going to give you the answer for this. Whoops. Maybe I just did. So I want you to read this and I want you to think about what signs there are that are important and what might lead you to the correct answer. He's been drinking, nausea, vomiting. He has hematemesis, massive bouts, so lots of vomiting blood. He got a really low blood pressure. His heart rate is like interesting, not slow. His temperature is pretty normal, but his respiratory rate is altered, his heart rate is altered, his blood pressure is altered. His heart sounds normal, lungs sound clear, no distension, there are bowel sounds, stool's negative for cult blood, then what's his problem? A hiatal hernia, esophageal laceration or Mallory-Weiss syndrome, Barrett esophagus, or an esophageal stricture. Okay, that's it. Y'all enjoy.